I'm very glad to introduce this roundtable, and we will be discussing about the Work Package 6 results and what was achieved in Work Package 6 and which might be the next steps for further implementation or to bring on what has been done by Work Package 6. We heard from Rokas earlier that Work Package 6 achieved great results, implementation in 6 pilot sites, more than 3,500 patients enrolled, great impact on outcomes, and also a common model for multimorbidity that was adopted in different implementing sites. So these were really a great results, I feel, of the of Work Package 6. So as I said, now we are going to discuss. We are now going to discuss what are the next steps, what can be done further to bring on what was achieved by Work Package 6. And in today's roundtable, we will have 3 experts that will discuss about future opportunities. Antonio Sarria Santamera from Nazarbayev University School of Medicine in Kazakhstan, Mirka Barbolini, EU Senior Expert, and Mieke Rieken from Nivel from the Netherlands. And after these 3 experts, I will ask representatives of Ministries of Health of Italy, Spain, and Lithuania, what is planned in their countries and what can be done further in the field of integrated care and multimorbidity. So my first question today goes to Antonio Sarria Santamera, which I see on the screen with pyramids on his back. I don't really understand what is there, but Antonio, as I said, is associate professor from the Department of Medicine of Nazarbayev, probably I did not pronounce this well, University School of Medicine in Kazakhstan, and he was the first coordinator of the CHRODIS joint action. So my first question is, did you think that we could have achieved such a good goals, Antonio, when we started? And
of course not.
Sure, no doubt about it. And the other question is a more general comment on the results of the work package and what you personally see as further steps from what was achieved so far and can be in the field of integrated care for multimorbidity. So Antonio, once again, it's a real pleasure to see you so far away from Kazakhstan. And I mean, we started together 3 years ago and we are here at the end together. So I'm glad that you can join us today. So please, Antonio.
Well, Graziano, thank you very much for this gentle invitation to be in this session to discuss the results from the Work Package 6 implementation. So it's a real pleasure that probably seeing what you have achieved in the last 3 years. As I said, when we started our discussions, probably we didn't know even if it was possible or not to get to this point, but we somehow imagined we could at least have this final conference with something to present. And I have to recognize that I'm sincerely impressed what has been achieved. So I have not anymore to congratulate all to have participated. But as I think one of the last things I said before leaving CHRODIS is that CHRODIS has become a real powerhouse of implementation. So it's really a well-oiled machinery to implement things. Let me, however, having said that, something that elements for this further. Yes, so we can congratulate, but now let's move further. So there's one main issue, which is I also have this problem, and to some extent you do. Is what is multimorbidity? So, but is multimorbidity having more than one disease, or it's a physiological situation in which you are, in the sense, closer to frailty, to other clinical situations? So this is so important if we think about the future. I think it's important to think about the future because I think also Antonio Gimeno said in his video that at the beginning this multimorbidity care model was something conceptual. Of course, conceptual based on experience of people coming from different fields that based on their previous experience, their review of the literature, came up with a model. And now, seeing what has happened, it seems to me that there's an obvious, it's what I may call the Bruce Lee phenomenon, which is be water, my friend. So the multimorbidity has had to adapt to the different situations in what was implemented, which at the same time shows to apparently contradictory situation. One, it's its flexibility, which is good to have something which is flexible enough to be applied in different circumstances, but at the same time, then here comes the other question, is there from this initial series of different domains to be applied, some of those elements which are critical, and in this process of refinement should be considered as necessary while the others are, say, supportive, facilitating, but not so necessary. So, because in this process of moving from this conceptual to proof of concept, things happen. And in occasions, things happen in a non-linear, unpredictable, and emergent fashion. So, because now the issue is we have to consolidate, or you have to consolidate what you have achieved locally, but it may be also good to have certain, sorry about that, local regional expansions, but also maybe considering about this more distance expansion. And in this way, after all the success achieved, is it possible to think about if something is really necessary, or at the other way, it's necessary to have everything aggregated because otherwise it won't work? So those are some questions that, well, you unrolled this multimorbidity model, and now you are roll it back. And in this process of rolling and unrolling, so a reflection on these issues from the overall concept of more physiological to the more practical of what the multimorbidity is, something has to be reflected probably for thinking about future implementation and extensions beyond the great success that I only can congratulate you for having achieved in these last 3 years.
Thank you very much, Antonio. I believe you're right. I mean, first of all, I want to underline what you said. The flexibility is a key factor for this, for what we have done. I mean, without flexibility, it would not be possible to adapt the same model to different occasions, to different situations. And second of all, the two great suggestions you're giving us. First, further implementation, local, regional, on large scale, but also sort of fine-tuning of what we have done in order to better identify what is necessary, what is not, what are the key steps to further implementation. And this clearly brings me to a question for the next expert, that is Mirka Barbolini. Mirka is a public health and EU senior expert, and she had a great role in the joint action because she really supported all pilot sites in order to review their pilot action plan, develop their implementation, and write down the final results. So Mirka is the person that has a great view of what has been done by the pilot sites, at least by the 6 pilot sites in Work Package 6. And following what has been said by Antonio, my question for you, Mirka, is you have a clear view of what was done. So you probably are the best person to tell us what might be the possible enablers and barriers to change, because what we really brought with the joint action was a change in practices. So my question for you is, which are these factors, enablers and barriers that can really represent a future step or a future target for further interventions? Because if we really want to somehow fine-tuning or better identify what is necessary, what is not, what are the aspects we should better focus on, we need to know barriers and enablers. So probably you're the best person to tell us how can we proceed further in this direction. So Mirka, the floor is yours.
Thank you very much, Graziano. I will try to give, within a short time available, just a few insights or significant insight. In fact, the groups had different modalities of implementation related to different settings. Overall, in terms of enablers, they found that the support provided through the design, the support for the analysis of this analyzing the situation and then drafting the plan and then following the plan and also analyzing the outcomes was something very important, as well as constituting multi-professional teams that and teams composed also by key stakeholders. That was one of the essential component of the pilots. And at the same time, to have going down into more detail, to have also referent person for the implementation, like the identification of a case manager, but at the same time also to have to allow healthcare professional agendas, daily duties, to allocate some time for to perform the pilot implementation, because clinicians not always are manager, and so it was important to set this aspect. At the same time, the barriers that could be common for those who want to embark in this experience is that there are always changes to in organizational aspect, either from the population but also from professional. The changes, of course, the implementation team worked on this, but these are just general aspect pointed out by the groups. The fact that the legislation was not always complete in order to consider multimorbidity, like the formalization of the case manager role, telemedicine services, the role of GPs, the resources, because the group worked with very limited resources, and despite this achieve great results. And I think the human factor is something very important in this context. The availability of reimbursement schemes that consider multimorbidity, but also the incentive for those who work on the implementation. At the same time, the human resources like professional turnover, not always allowed coordination, and also the training, limited training that was overcome by the initiatives, limited training on care of multimorbidity and sometimes on management principle. One other aspect mentioned by group was that it's not always easy to integrate care practice between health and social care, and neither share resources. So these are important aspects to be considered for potential future implementation. And for the factors that could support future scaling up and sustainability according to the European Commission criteria as well, is that the model component need to be embedded within long-term plans and strategies. Of course, it should be based on evidences, but they should consider also, as done from the implementation groups, what are the benefits for patient, for professional, for care providers, and the groups, the nature of the groups, of the implementing group, demonstrate that it's very important that key stakeholder, policymaker, and professional are involved and have a strong commitment. And this has resulted in adoption of new policies and strategies, adoption of component of the model itself. So it's very important that the groups represent all possible stakeholders that have a say in change policies and change management processes. It's important to work on intersectoral collaboration because multimorbidity, I would say multimorbidity, and also that is affecting more and more the aging population, is a complex condition, so require different resources from different sectors. And primary care, certainly thinking about integrated care, is a very important pillar, and so need to be strengthened as much as possible in order to reduce unnecessary access to emergency services and hospitalization. And of course, as I was mentioning before, it's important to analyze cost, to have a careful allocation of resources, and to think also possibly to sort of incentives that are linked to the model's objective. And at last but not least, working on human resources capacity is always an essential factor, allowing, especially at the local level, allowing professionals to be trainers and also to be disseminators, as mentioned by some groups, to work remote education, as well as training of trainer methodologies to involve patients in order to facilitate their self-care also. Thank you very much.
Well, this was thank you, Mirka, a very long list of factors and things we can work on for further implementation. I would like to summarize what you said. I mean, there are factors at the system level, reimbursement, for example, organizational level, personal level, And I want to underline two of the factors that you have mentioned. Active involvement of all stakeholders. I feel that this is really key in order to make the change and to provide good results. And the other factor is money, is costs, that clearly drives almost everything we are doing, especially in this period, especially in Italy, but probably in all countries. So these are other two factors that are absolutely key in order to make the change. So thank you very much, Mirka. I think it is a good overview of the factors that are important that we should consider as barriers and potential enablers for further implementation and further and future steps. The third expert I'm interviewing today is Mike Rieken. Mike is a friend because we started together the first CHRODIS joint action. Then she was no longer part of the second CHRODIS Plus joint action. She is a senior researcher at NIVEL, the Netherlands Institute for Health Services Research, and professor of international health and social care at the University of Eastern Finland. So Mike, as I said, she participated in the first CHRODIS joint action, but she is also part of many initiatives at the European level in the field of multimorbidity and integrated care. She led the I Care for EU project, which is a project that was focused exactly on these two topics. So my question for Mike is, I mean, you have a good overview of many of the European projects and activities, or several of European projects and activities in this area. So in the area of multimorbidity and integrated care. So my question for you is, which do you think are the commonalities of CHRODIS Plus and other key activities or important activities or projects at the European level that can deserve specific attention or further implementation? I mean, based on your experience, which are the common points of CHRODIS Plus and other activities in European activities in this field, and which do you think may be the commonalities that may need, or which may be the things that may need further study and further implementation in this? So thank you, Mike, the floor is yours.
Yes, thank you, Graziano. I hope you can all hear me well. Yeah, I see several commonalities with other integrated care initiatives that we, as you said, also identified when we conducted the I Care for You project, but also what I've seen from more recent EU-funded projects, such as the Self-Feed project and Sustain project, which both were also working on developing integrated care and implementing integrated care with local groups. In that case, in the Sustain project, it was care for older people, and Selfie was focusing on multimorbidity as well. If I compare these initiatives with what I have seen from CHRODIS Plus, I think for me, the clear added value of CHRODIS Plus is in the integrated multimorbidity care model, that there was a common basis for developing interventions, integrated care interventions, and also for implementing them. And what I've seen in the other projects, but also in what we did ourselves here in the Netherlands, as we also did some small pilots based on the model. But what you see is that there are really many very motivated care professionals and managers who are willing to work on this, but they need guidance and they need support. And I think that by working with starting from the model and adapting elements that you feel that serve best what you should change in the local context, that is very, very helpful. Also for the development or implementation groups to ensure that what they are going to do, that it is that their plans are coherent and that they indeed respond to the highest priorities and needs in a specific environment. What I can add is perhaps what we did in the pilots that we did in the Netherlands, which I said we also use this model. We use it as a sort of self-evaluation instrument. So the local implementation groups, they conducted the self-evaluation. We asked them to review every element of the model, say to reflect on whether they were happy with how they did this element, or whether they wanted to improve it, etc. And that was also really helpful for the groups to define their goals and also their specific action plans. So that was really helpful. If you say what are common points that I've seen, what we think, well, we need to work on. I think it has already been mentioned several times at this conference, but for me, I think most important is that we explore, that we try better to involve people with multimorbidity and family or their carers also in designing the integrated care services. I think you did a very great job, and I want to congratulate all of you who worked at the pilot sites, because it was impressive what you have achieved in 3 years. And I remember that at the start of CHRODIS Plus, I was in a meeting, and we discussed whether it would be feasible to include the patient perspective in evaluating the results. And well, you have done that all, and I really, I want to support really that this is so important. And I think I'm going to repeat myself because I've said that already many, many times. But the evaluating, assessing the experiences of the people whom it concerns, this is, I think, the most important outcome domain for integrated care for people with high care needs. But I think as a next step, and also to bring it further, I think we could and should try to do more to involve people with multimorbidity and family members also in designing the integrated care services. I know that there have been, there were focus groups. We tried something with a survey asking the preferences and the priorities of people for the specific elements of the model, so what they felt would be most important to work on. And I also know from Sustain and other initiatives that people with multimorbidity and family members were invited to participate in the local development groups. And so these are all ways to do this. And I think this is really something that we need to see what works well and learn from each other in that respect.
Thank you.
I want to add one thing that is already mentioned, and that is also one of the commonalities that I see is the barrier that was also, actually I echo Mirka now, because this was one important barrier is I think the lack of human resources. And we all agree that strengthening primary care and community services is actually the backbone for further developing integrated care and scaling up. But what we see already in countries is that we have a shortage of primary care doctors and definitely also of nurses. And they are so important in further implementation of integrated care. So this is really one of my main concerns. And of course, this is something that asks for clear vision and measures at a higher level. But yeah, I think this is already echoed.
Thank you very much, Mike. Thanks a lot. Your view is relevant. I mean, the involvement of patients in designing of the intervention may be a further step, and also the lack of human resources, as you mentioned, is a problem that is really at a system level in many countries. I mean, in Italy we are absolutely the same issue and the same problem.
Yes,
so
sure.
Thank you very much for your contribution. Then now I will give the floor to the representatives of Ministry of Health. We have the opportunity to have with us the Vice Minister of Health of Republic of Lithuania, Christina Garuwarya. You may apologize if I'm sorry if I did not pronounce it well. Vice Minister, we know that Lithuania was particularly active in implementing the integrated care model, and really a huge effort was done. 2 of the pilot sites we had in Work Package 6 were from Lithuania. So I want to have your view of what you see is important in the joint action, and what has been done and it's on the way in Lithuania. So please, Vice Minister, the floor is yours, and thanks a lot for being here today.
Thank you very much. So I will start, and my colleague Gitana will later explain more details about our projects. So, as you know, in all countries, aging population and increasing prevalence in multimorbidity puts a lot of weight on healthcare systems, and really in current situation with COVID, we also see how multimorbidity, how it's difficult to cope with such problems. So in order to ensure high quality, affordable and effective health care to those patients, policy support and clear country strategy are essential. And on another hand, it is extremely important to have science-based methodological recommendations for those changes. And this is where CHRODIS and CHRODIS Plus results proved to be beneficial when defining priorities and ways to achieve those on national level. In order to identify opportunities, Ministry of Health and CHRODIS Plus have numerous discussion, exchange of data and evidence, as well as feedback from local groups in the country. The cooperation with CHRODIS Plus results significantly contributed towards the national pilot and integrated care supported by healthcare priorities, ensuring adequate engagement. And I will ask Gitana to explain more detail our project.
Hello, everybody. I want, in short, to tell that in 2020, the public call to test integrated multimorbidity care models across different regions in Lithuania was initiated. And this support from European structural funds, Ministry of Health of Lithuania chose to test science-based integrated multimorbidity treatment models. 15 leading primary health care centers with relevant stakeholders and partners have started to implement integrated care model adapted to their local context. And CHRODIS or CHRODIS Plus outcomes play an important role in the defining sections and components. The first section, delivery of the care model system, is included in all models, and total number of 46 primary health care institutions will be running this program for 2 years. Test of models will be conducted in 23 municipalities. It is more than third of overall number of municipalities in Lithuania, and 726 multidisciplinary team members will be involved and trained over the 2 years period. 4,764 patients will directly involved and receive benefits from integrated multimorbidity care models. And in all multidisciplinary team are involved general practitioners, nurses, medical specialists, public health care specialists from primary health care institutions, and from 12 public health care bureaus in municipalities, and involved also social workers and other specialists. And the Ministry of Health of Lithuania will be assessing the outcomes, including economic benefits, with a goal for the most effective and inclusively adapted multimorbidity health service models to implement at the national level. So ensuring sustainable value for the healthcare system, potentially contributing towards value for patients, caregivers, and the health care system. And expected benefits of integrated care model are to increase healthy life expectancy, clinical outcomes, service availability, number of remote healthcare services, reduce administrative burden, increase professional competence, and ensure better collaboration between team members and better working conditions. In the long run, we would be watching out if the values could include reduced number of hospitalization, especially avoidable hospitalizations, outpatient visits, home visits, hospital readmissions, and seek for optimized usage of resource. And what about, and shortly, about strategic documents? On the action point of family medicine development action plan for 2016 to 2025 in Lithuania is development health care for patients with multimorbidity of non-communicable disease. Strategic goals of family medicine development action plan to improve service delivery, accessibility, quality, and continuity, as well to increase financing and ensure adequate qualifications of professionals working in family medicine. And in 2017, Lithuanian government ran structural reform reform covers 6 areas, and one focus area is health, and the Ministry of Health carry out health structural reform. Health structural reform consists of 5 projects. These projects are healthy life promotion, optimization of hospital network, establishment of measures aimed to reduce expenditure of medicines, development of nursing care services, and development primary health care services. And the strategic goal of primary health care development project is to improve the quality and availability of health care services, reduce the waiting times for visits to GPs and medical professionals, reduce the number of cases of avoidable hospitalizations. And one of these projects action is development in innovative models of care of multimorbid patients. And briefly, I want to present main actions that are being carried out in context of these projects and help to develop patients with multimorbidity health care. It is a family physician team has been supplemented by lifestyle medicine specialists, nurse assistant, social worker, kinesiotherapist, remote patient counseling become fully operational and widely accessible to patients all over the country, and it is element of success that has protected the medical profession and supported the provision of services. And new services, remote consultation doctor to doctor, introduce the possibility increase access to healthcare services. In conclusion, I would like to say that CHRODIS Plus project and implementation of integrated multimorbidity care models is one way to reach strategic goals and mentioned in strategic documents. Thank you.
Thank you, Gitana. Thank you very much. It's impressive what has been done in Lithuania, and it's very good that the implementation has been brought further in this country. And your intervention and the intervention of the Vice Minister really helped me to answer one of the questions I got here on the chat box by Theodore, because in your case, it's really a great example of a situation in which a project such as CHRODIS Plus has supported or was used as a basis to further implementation and change something at the country level on a larger with a larger implementation. So the answer to Theodore is that probably we are not going forward, or we may have some difficulties in going forward at the European level, but at the country level, there are relevant initiatives that are ongoing and that can bring forward what has been done by CHRODIS Plus. And I will move now to the Spanish representative of Ana Cariazzo. I'm asking Giovanni Nicoletti to wait. He will be the last speaker. I'm sorry, Giovanni, but women first. You don't blame on me, but I mean, probably have to leave the floor to Anna first. So Anna is Senior Advisor of the Regional Ministry of Health and Families of Andalusia. And so Anna, for you, the same question that I have for all the representatives of Ministries of Health. Is a scale-up plan in your country, and by which strategy? What are the future steps in Spain after the joint action CHRODIS Plus has ended?
Thank you, Graziano. Can you hear me well? Okay, so the first question to your, the first answer to your question is yes, and I will comment on the national level in a moment. In this occasion, I have two hats. As Graziano said, I'm working at the Regional Ministry of Health at a subnational level, but I've been in collaboration with the National Ministry of Health in Spain to provide you with their insights regarding the further implementation and scaling up of the CHRODIS Plus integrated care for multimorbidity in our country. Let me start by saying that in Andalusia, we were one of the implementing sites in Spain together with Aragon, and both of us, both regions have implemented the integrated care for multimorbidity in primary healthcare. It is a strong network in our region, in our different regions. As you may know, Spain has a very strong decentralized health system based on the regions. Andalusia is starting to implement the personalized action plan, that individualized action plan of the morbidity, the integrated care model for multimorbidity within their regional strategies that was launched in 2012, a comprehensive plan for the care of patients with multiple chronic conditions and the care strategy. And that has helped, together with the corporate electronic health record and other solutions that we had in place, to roll out and to show the results that were commented previously. I'm not going to go through them again, but probably one of the main assets that we have, the main results that we have collected from the implementation of the care model and of the PAP is the specific evaluation and assessment of quality of the plans, that personalized action plan that are applied to people. And there are still room to improve, and we plan, and the results have been presented internally, and they plan to roll out further implementation and improvements in the collection and development of personalized action plan. Regarding the national level, that is the most important thing to comment and to share with you. There is a national strategy tackling chronicity at the national level, launched also in 2012 from the national ministry in collaboration with all scientific societies, representatives from professional associations, patient associations, as well as the different regional ministries of health. And this strategy had a the aim to promote a change in the management of the care of within the National Health Service to improve the quality of the care provided to the population. This strategy was recently assessed in 2019, and based on the results of this assessment, a number of recommendations that were shared by the National Ministry through the governing board with the CHRODIS Plus project. There are a number of different lines of actions that are going to be undertaken from the National Ministry. And I would like to highlight some of them, and I have in front of me. The first one is to foster and promote the development of these models of health and social care towards an integrated model for multimorbidity, and strengthening primary health care. We all are aware of the shortness of primary healthcare professionals, both family doctors or community nurses and other professionals, social workers that are working in teams in our country, but still there is a specific aim from the ministry to strengthen this level of care as a pillar for the care of people with chronic diseases and fostering patient-centered care. Second line of action is to strengthen prevention and patient empowerment, involvement in their own self-care, and to develop operative self-care plans with the help of nurses, primary healthcare nurses at a primary healthcare level, and with the help and support of the network of School of Patients that we have in Spain. There was a presentation from the Cantabria implementation site for the board package 7 that included that, and there is also another one. There are different School of Patients in the different regions that are all within the national network and is accessible in their webpage. To end, the last consideration that the National Ministry is putting in place is a program to foster home care that has been shown in the evaluation that is improving the care and the situation of the people with chronic conditions, avoiding inpatient episodes that are potentially preventable. So there is a specific program to try to foster home care or telecare within the national health system. And I think this is what I would like to comment from my side. It has been an honor for me to be able to share the national view, not only my regional and of Andalusian view, but also the national view. And it's a pleasure to be in this panel. Thank you.
Thank you very much, Anna. Thank you very much for your contribution and for the contribution of all Spanish partners in this joint action, and particularly in this work package on integrated care. So last speaker, Giovanni, last but not least, my adventure with CHRODIS started about 7 years ago with Giovanni, with a terrible travel to Luxembourg. Giovanni, you may remember that. It took us almost 1 day to reach Luxembourg from Rome. And now my adventure with CHRODIS ends with you again. So Giovanni, you are the last speakers, and I would like to hear your opinion and the opinion of the Italian Ministry of Health on this joint action, and more specifically on the work package on integrated care in multimorbidity. Giovanni, the floor is yours.
Thanks, Graziano, and thanks to all the colleagues for inviting me to this roundtable. I'm not sure if I want to speak about Italy only, because I've been involved with several other players in this wonderful project. And I don't have the wonderful background that Antonio presented, but I want to take inspiration from that, because I'm not sure if it represents a sunset or a sunrise. And in this doubt, however, what we know from this joint action is that member states and government are usually involved in joint actions at the very beginning, at the very end. The beginning to nominate partners and to struggle for budgets, and at the end because someone is expecting that member states will take over solutions, recommendations, proposals, and do that on their own at home. And not to counteract what you were saying, but I still believe there is a lot of European work that we can do on chronic diseases. And joint action, CHRODIS Plus and CHRODIS before, has been a flagship initiative of what Europe and European Union and member states together can do if they only wish to work together. And I still rely that most of us at least will still want to work in several different ways, maybe not in a joint action, but with other kind of projects in order to have the legacy of CHRODIS and several other initiatives that have been run in these years or concerning chronic diseases. And my colleague Paolo Michelutti will speak in the next session about what we have done in CHRODIS to involve member states and also of our proposals and idea on how to go forward after CHRODIS will end. And we strongly rely that other member states will also support this perspective. Coming now to Italy, I always say that it's very difficult to understand what will happen in Italy the day after. So speaking really about the future is not an easy task. But let me say that despite we are speaking in the worst possible moment, and maybe we were not figuring out how many things CHRODIS could produce in 3 years, but for sure we were not forecasting to have this conference virtually and to have all the problems that we still have. Instead, that relaxed discussion that you usually have in final conferences. But on the other side, one of the very few consequences, positive consequences of the emergency is that there is a renewed interest in investing in health, at least in our country, and there is a renewed interest on invest on things that were apparently not in the high segment of the agenda before, and in particular chronic diseases, chronic care and prevention, and primary care and community care in our country are again in the agenda, and there is a real willingness, at least from the government perspective, but I guess also from the local authorities, to use the funds that will be available in the next European plannings to have serious revolution in all these fields that honestly in the theoretical planning were always very important and were a priority declared by all the authorities, but when we were going to implementation, really there was a need of a scaling up and really having a new wave of actions, because most of the things that we were highlighting also in CHRODIS were partially or integrally reported in our planning 10 years ago, but very, very limited actions then were implemented. Now I think that the times are changing. I'm not an optimist usually, but this time I'm a bit more. And CHRODIS has been a master plan in order also to describe our future agenda. We have a full list of programs and projects and actions that have been run in CHRODIS. I don't want to list all of them because you have heard during the conference. Just to mention, for us in Italy, we will have a new prevention plan that clearly focuses mainly, but even not exclusively, on chronic diseases, risk factors, and in particular in this lifelong approach that for us it's essential to achieve results on chronic diseases. And we will have also increased the chronicity plans investment for people which are in the multimorbid phase. And so for those we are really needed to receive care and not just prevention. But let me conclude to highlight one, but be not so too much repeatedly aspect. When we work together as a group, it always seems that we are having the same opinions, and when we have different opinions, we sit down and produce something that it's apparently a good synthesis of all what we have. Then we go to real life, and we find new stakeholders, additional players, other politicians and other people that we have to convince that what we have done with other colleagues was the best choice. Let me say that this time in this project, we have run things a bit differently. We have started to speak with these people during the project and not afterwards. We have started giving evidence during the project and not afterwards, that maybe little things or limited area things are feasible and are also acceptable to the people that have to implement them. So not really a top-down approach as we have done several times in the past, but something that really have shown evidence on also of the paths, as was described by Mirka, that they have to be followed. This, I think, it's something that it was not very common in previous experiences, and we have to highlight that CHRODIS for the first time describe also a new wave of doing European projects. That's why I'm still asking, I'm sorry if I'm repeating that too much, that we need more Europe, not less Europe.
Thank you, Giovanni. I mean, your intervention nicely closes this session. The importance of a bottom-up approach, and that is what we have done in CHRODIS, and starting from evidence on the field, changing the policies and the practice at the national or regional level is absolutely important. So I'm very late. I see Zoltan is very upset, and so I really thank all participants to this roundtable. I'm sorry there's not enough time to have further discussion, but once again, I think we really achieved great results that have changed and might change practice as a regional level in many countries and in many situations. I thank you all the speakers very much, and I leave the floor back to Zoltan.